Good afternoon, everybody. I am going live today as part of National Infertility Awareness Week, hence wearing orange, with the founder of Brown Fertility Clinic in Florida, US. And we are going to be talking about, and Dr. Brown is kindly going to be answering any questions that you may have around the definition and the difference or the meaning between being diagnosed infertile and having fertility issues. So they've written a fabulous piece for us, which is linked up in our bio. So I highly recommend people go check it out to have all of your questions answered, and for more expert information. I'm going to see if Dr. Brown is here. We haven't been live together yet, so this is an exciting time. And hi to those who are joining. As I just mentioned, I'm wearing orange today because I like the colour, but also because it's National Infertility Awareness Week currently in the States. And so here he is. Let me add him now. So joining, nice to see you. Hi, everyone. Hello, good afternoon, Dr. Brown, or good morning,
Hi.
should I say.
How are you? Thanks for having us.
It's lovely to meet you like this, face to face.
Nice to meet you.
So I've given a brief introduction to you that you are, of course, the founder of Brown Fertility Clinic in Florida. And I've just been talking a bit about the fabulous article that yourselves have written for us around definitions between fertility or fertility struggles and being clinically diagnosed infertile, which we're going to talk today about. And I'm wearing orange because it's National Infertility Awareness Week.
Awesome.
But to our viewers, and then we'll start.
Awesome. That sounds great.
So tell us a little bit about you.
My name's Samuel Brown. I'm a reproductive endocrinology and infertility specialist, and I'm a graduate of the Jones Institute, where they had the first IVF baby in Norfolk, Virginia. Amazing. So I was able to train other people who really invented modern IVF. And we're real busy. We're probably the biggest, I think we're the busiest group in Florida. We see a lot of patients and do a lot of infertility and IVF treatments. And very, very nice and busy. You
have lots of locations, don't you?
We have 18 locations all through Orlando, Tampa, and Jacksonville, as well as Georgia, Valdosta, Georgia, Albany, Georgia, and Tallahassee.
Amazing. Amazing. And what are Brown Fertility Clinic doing at the moment for National Infertility Awareness Week? I've seen some lovely videos and things. What's happening over there?
Yeah, we try different skits and social media add-ins for trying to keep awareness for infertility treatment and awareness for sure.
Fantastic.
We've done a lot.
I love the pineapple in the background in your office. So may I ask you some questions on the topic that we're discussing today? And for those who are joining, hi, welcome. I have the pleasure of speaking with the founder of Brown Fertility Clinic in Florida. Sorry, the light's gone off in the room I'm in. And we're talking all about sort of definitions between a fertility struggle versus being diagnosed infertile and options. And they've written a fabulous article all around this, which is linked up in our bio. So for further reading, please head there. The first question I wanted to ask you was, please, could you kind of define having fertility issues versus being infertile?
Sure. Well, the scientific definition of infertility depends on the woman's age. If the woman's under 35 and she has more than 1 year of just random sex, it doesn't have to be targeted sex, with no pregnancy success, that's infertility. So she has primary infertility if she's never had a baby before. So just 12 months of whenever sex, if she's not pregnant, that's infertility. Then we start diagnostic testing and treatment. Now, if the woman's above 35 to 40, it's just 6 months. Just having sex for 6 months, if there's no pregnancy success, then that counts as infertility. And they should come in and have some tests and potential treatment. And for a woman over 40, it's right away. They say, don't even wait. If you can go see the fertility specialist immediately, because time is truly of the essence if the woman's over age 40. So that's kind of how we look at it, as the scientific definition of what infertility is.
And what about in men?
For men, well, you're right. So when you look on the man side, well, if he's had a vasectomy, we know he's infertile, right? So you don't have to wait 6 months or 12 months or whatever. So if the guy's had a vasectomy or has a super low sperm count, then you can start treatment right away. You don't have to wait 6 months or 12 months or what have you. So getting that you're spot on. That semen analysis is like one of the first tests we got to get.
Yeah.
For sure. And there's other scenarios that you don't have to wait at all. Like in your PCOS patients or women that are not ovulating, you don't have, if she's not getting her period, you don't have to wait 6 months or 12 months. Like if she's skipping 30, 60, 90 days with no period, we know she immediately has infertility. So she doesn't have to wait 6 months or 12 months or what have you. She can come in immediately. So you're right. There's those or the interesting case scenario is the miscarriage patient.
Okay.
If she just continues to miscarry, she can come in immediately. She doesn't have to wait 6 months or 12 months.
And would you recommend that people do seek help if they've experienced how many miscarriages, for example?
So scientifically, we call a recurrent miscarriage problem or infertility if they've had 2 consecutive miscarriages. However, the line that we need to educate is even if the woman has a miscarriage or doesn't even really have infertility, if she's just thinking about it, insurance pays for them to come in and have a chat. So it's okay just to do family planning, and the woman may not even have infertility, and she came in and wanted to hear about it, or the couple came in to hear about what is fertility testing and treatment, and we may not even do any testing or treatment. We'll just tell them when to have targeted intercourse or what have you, and they get pregnant on their own. We just kind of tell them how they're supposed to do it. And we don't even have to wait 6 months or a year at all.
Do you see quite a lot of people, like more so in the last, let's say, 5 years, from there being more education around fertility and fertility age and issues? Do you see more people coming in at an earlier stage just to get checked because there's less of a stigma about it? Weeks like National Infertility Awareness Week are helping so much to drive the conversation and for people to think, hey, it's actually okay to see how my fertility is.
You're really right. I think our culture is changing, and I think patients and women and men have more courage to, they don't have the stigma, and they're okay with asking and getting information. And you're seeing less and less of the stigma for sure, where it's okay to ask for help or ask questions and not delay things. And I think that is increasing our services. If couples aren't getting pregnant right away, they come in, they don't feel guilty about it or feel weird about coming in. They just do it. That's great.
Yeah. My husband has Klinefelter syndrome, and he has azoospermia, obviously, as a result. And so he's clinically infertile and had microtesty years ago, 6 years ago, which was not successful. So we had treatment with donor sperm following, and now, fortunately have 3 young children close together.
Awesome. Congratulations.
So thank you. So that's why I started this, because of the lack of support out there at the time. But it's hard to know, isn't it? So we were thinking about the male side. We were in this strange position when my husband got a semen analysis back in the UK when we first went for just standard tests, age 30, after trying for 6 months. He suddenly got a result which said 0 sperm, and we just didn't have much support at that time, and we didn't know how to read into that. Like, what was next? What were our options? It was a very confusing time. So do you see that a lot, where people just feel desperate that they just want to know what their options are?
I agree. I mean, even though the stigma is going down, it's still there, and it's just so emotional. Infertility is more emotional than any other area of medicine, and it's such an emotional roller coaster, up and excitement and down to lows, and it evokes a lot of emotion. Family planning, and your thought and ideal of having a family gets crushed, and then it's revived and crushed again, and so I think everyone's emotional. I think if to not have some of those feelings, I think you're a robot. I think you have to have emotion but like you said, though, our cultures are such that people are breaking away from that and having enough courage to come in to talk more and more, but we're not all the way there yet. You're right. You know, it's still, it's emotional when you find there's a bad issue, when there's and something that's going to change your family plan or your life plan. It's very, very emotional.
So if you had, I'm sure you do see patients, of course, who come in and they, you know, on both sides, they may have a semen analysis that is, you know, really bad sperm DNA fragmentation, or no sperm, or very, you know, little sperm, or on, you know, female side, perhaps very low egg reserve. What are the next steps? What can people do following that?
Yes. So there's a lot of variation there. Like we'll start with the men. It's a little more straightforward, where if it's just a mild sperm problem, those couples get pregnant pretty easy. You know, even intercourse at home or inseminations. But if it's really low, then well, first we try to figure out, can we fix this? Can we put them on a medicine and make it better? Can we get them off testosterone to get it back to normal? But if not, if it's really low sperm counts, then pretty much IVF is the only option, or considering donor sperm. You're exactly right. Now for the female, it's a little different. So, but you're right. What's really important is the egg count. And usually the woman's age will tell you about her egg count for the majority of the time. And if she just has a little hit in her egg count, not a big deal. They usually get pregnant simple, just like the man. If it's a moderate, then yeah, they still have options like inseminations or IVF. But if it's like a severe hit in the egg count, then we got to consider things like IVF or donor egg also. And age, the female age is very predictive of what her egg count is, or how the quality of the eggs.
Yeah.
So you can usually tell just by the woman's age what's going to go on with her egg count usually. But we have a blood test to look for that too. We look at AMH levels and FSH levels. For the man, it's simple. It's a sperm test. Semen analysis. So we do handle both. And it's very common to have couples where they got both. They got like a mild male factor and a moderate female factor. And then you kind of have to piece it together. What's the cheapest way out for that couple to have a baby? And yeah.
Do you see lots of people coming in who may feel, lots of patients who may feel, and we see this in the community, but feel totally not necessarily shocked or sort of disbelief that they're in this situation, and the thought of IVF is very overwhelming, and then even like moving on to donor conception might be a step a little bit later for consideration, because it's almost like taking little steps one at a time to get over for acceptance.
Exactly. It's a common hurdle, a common issue where if the couple requires a more aggressive step, like not just intercourse or insemination, but they need IVF, it's a little harder to pursue that. And especially if you go to using donor, third-party reproduction like donor egg or donor sperm, and it can get to the level of a surrogate. So that's one of the more complex things we do. But you know, in the big picture, it's pretty easy to do. It's not as expensive as people think.
Yeah.
And it works. You have a baby, and generally speaking, it's a lot cheaper than adoption. You know, I'm a Christian dude. I'm all about adoption, but man, adoption these days in the U.S. is hitting like $70,000. And like, for example, a donor egg cycle, if the woman needs that, if she's over like 42, 44, we're the most affordable. It's like $15,000, something like that. So it's way cheaper, but adoption is still a viable option. And you know, couples sometimes will still get pregnant despite having a really bad case scenario, like a really low sperm count or a really low egg count. Sometimes they get pregnant on their own. And we kind of factor that in when we have in those conversations. Yeah.
Yeah. And there are actually two people that I know well in this community who have been trying with fertility treatment for literally nearly a decade, and they're both now pregnant naturally and just in disbelief after so much money and time and heartache on, you know, even donor cycles and things like that. So it's unpredictable, isn't it, fertility?
Well, I think an important point, and you brought this up earlier in designing today's talk, there's infertility and there's subfertility and there's normal fertility. And most couples are subfertile. So what do I mean by that? Well, normal pregnancy rates 20% per month for couples in the right age group, et cetera. And if a couple has infertility, well, it might be 10% per month or maybe 3% per month, but it's most of the time it's not 0% per month.
Yeah.
So,
Yeah.
and even that woman that had like with unexplained infertility, her chances are 3% per month. We have chapters on this. We've looked at millions of couples with unexplained where you do all the tests and they're all normal. Well, even that unexplained couple, if they just have sex at home for up to 5 years, it's a 35% chance they'll get pregnant on their own. So, but you hear the word infertile, you think, oh, that's 0% chance per month.
Absolutely.
Most couples are subfertile. It's not 0%. Unless their ovaries are missing or they have 0 egg count or 0 sperm count, then it might be true infertility. But you're right. I'm so glad that you were bringing that up.
Yeah, absolutely. I was going to ask you a couple of questions. We've had some questions come in. First, before we answer these, I'd just love to ask, go back a moment to sort of fertility testing. People coming in for the first time, what can they do to find out what sort of degree of whether there really is a severe issue or not?
It's 3 simple tests. And we hope that if the patient is seeing an OBGYN doctor or a primary care doctor, that they can order them before they come in to see us. But if they don't, we get them ordered for them. But it's 3 tests. The sperm test, oh my God. And that's one of the hardest ones to get. I mean, most guys would rather break a bone than have to do a sperm test. Good God. But they'll do it under coercion. And that's so important, that sperm test. And you can call your local fertility center and just get it scheduled. Most of the time, you don't even have to have a referral. It's usually like $100. It's cheap. It's not this outrageous test. You have to worry about it financially. So sperm test, number 1. Number 2, HSG test or hysterosalpingogram. Simple old-fashioned test. It's like a pap smear where you come to a fertility center or you have it done, the OBGYN will have it done at the hospital, where you squirt a liquid into the uterus, kind of like a pap smear, under an x-ray machine just to see if the tubes are open and if the uterus looks normal or not. That's the second test, the HSG. It's best to do between cycle day 6 and 11. And then the third test is a blood test on the woman. We generally look at her like a TSH, a thyroid, a prolactin level, and maybe there's a blood test that can tell us a little bit about her egg count, like an AMH level or FSH level. It's a simple blood test. So semen analysis, HSG, and blood test. And when patients come to see us for the first time, oh man, if we have those in front of us, then we can talk turkey. Then we can really tell what's going on and go from there. But it's okay. If couples don't have that, we easily arrange that for them. And then they come back and see us a month later after they complete those tests.
Do people who get diagnosed with unexplained infertility find it very, very difficult because it's like, we haven't found a problem, so how can we fix this?
You know, and I'm so glad you brought it up. You're hitting all the right questions perfectly. So unexplained infertility, oh my God. You're going to a doctor and he or she says you have unexplained. Well, why did I come to a doctor? And well, we know what that means. And what it means is those 3 tests were normal. The 3 tests we just talked about. Yep. Well, we know what unexplained infertility means. And then we give the patient comfort because why I say this to them is we've looked at millions and millions of couples with unexplained infertility and we know how to treat them. We know that 70% of the time that woman will have endometriosis and not know it. So we know this. So then in those patients, we start with simple stuff. We do the current standard of care is we do 3 tries of the simple stuff we do, which is either Clomid or letrozole pills with inseminations. And if they're not pregnant, then we go to IVF. And they've shown that to be the most cost-effective way out. That's the cheapest way out. And that's what we currently do.
Okay. And does that see good success rates?
Oh, yeah. So if the woman's 35, most get pregnant on the first or second try of the simple stuff. But with IVF, like for us, we're fortunate. Every 1 try of IVF, if they have to go to IVF, it's an 80% chance of success with putting 1 embryo back in the uterus. Wow. And we're the cheapest. It's like $9,000 or $10,000 or something like that.
And how many embryos? How many embryos do you transfer at Brown Fertility?
Well, for women, the standard of care is if the woman's 40 and under, you should put 1 in. Sometimes if the woman's 35 to 40, we can put 2 in. Over 40, you can put 2 in as well. But that's changing all the time. And I'm glad you brought that up because they're going to try to make it illegal to put more than 1 embryo in a woman.
Really?
like they
Wow.
do in Sweden. Like in Sweden, it's illegal to put more than one in, and other countries. In the United States, I think that would be inappropriate for the government to try to control women's health care this way, because we kind of know what's appropriate and what's not
Hmm.
appropriate. And if the government's not paying for it, then they really should butt out of it. So hopefully it never becomes a law, because you don't want the government really telling you what to do medically. They're
I
not
have,
medical experts.
no, I have twins from a double transfer
Awesome.
5 years
Yeah.
ago. 5 years ago. Yeah, exactly.
You know, it's
Um,
funny. I think half our patients love the idea of twins and half
yeah,
hate the idea of twins.
yeah, I
But
know.
thank God we're not in that era. We used to have triplets and quadruplets all the time. So thank
Yeah.
God those days are gone.
Hmm.
We've actually cured. We don't see triplets or quadruplets anymore at all in the United States. But we do see a fair share of twins, and yeah, a lot of patients want to shoot for twins. Absolutely.
But that's a bit of a misconception, isn't it? In the fact that, and I remember thinking this at the time, just assuming that my chances were much higher by transferring two embryos.
Right. Right. It's a good
But
point.
actually, it
You're
just
very
increases
smart.
multiple pregnancies, doesn't it?
Yeah. So if you put one embryo, like if the woman's a young age, like under 35, that's considered young. Okay. If you put one in, like at our center, we have about a 60 to 70% chance of being pregnant. If you put two in, it increases at about 10%, maybe 20%.
Okay.
But I think the better way of looking at it, and this is not common sense, but let's say the woman has four beautiful embryos, probably only one of those is going to make a baby. Even though, because the genetic testing isn't even accurate on telling you what's going to be 100% effective. So I still, it's becoming an old fashioned to say this, but by putting two in at a time, you're getting closer to that one normal embryo. Let's say if she had one baby out of the four embryos, by putting two in, it gets you closer to that one. But insurance companies hate this. You know, they're worried about twins and they don't want to have to pay for twins. So, oh my God, they doggedly attack putting two embryos in at a time.
Okay.
But the majority of the time, when you put two in, you get one baby out. It just ups your odds a little bit. But they're really forcing us to put one in at a time. And thank God we're in an era where success rates are pretty good with putting one in at a time.
Mm-hmm. And there was a question actually about, support for same-sex couples. For lesbian couple, for example, what would be your route to parenthood? What would be the options there?
Sure. Same-sex couples, we treat them just like any other couple. I mean, if there's no sperm, then you use donor sperm. Just like a couple that has a zero sperm count, you use donor sperm.
So would you
They
start
also
with
have the extra
IUI?
option. They have the extra, so donor sperm insemination. That's right. That's what, and that's what we would do for them. They have the extra option. They can do, we call it reciprocal IVF, where they could,
Yep.
you could take one woman's egg, fertilize it, put it in the other woman's uterus. That's fairly common these days, called
Pretty
reciprocal
cool,
IVF.
isn't it? Yeah.
Yeah.
And also for solo parents by choice as well. There are so many of the same options.
Yes. Solo mom by choice or single mom by choice is really getting more popular. Women, they know they're at the age where things are getting tough with their family planning, and they just choose to go and have a baby, and that's okay. It's acceptable.
Mm-hmm. Absolutely. We've had some questions come in. Do you have time to answer some of them, please?
Sure. Yeah, absolutely.
And if anyone else has any questions for Dr. Brown, please ask. Also, I've linked up the brilliant article that they've written, which goes over into this in more depth. And there are contact details for their wonderful team. So please do reach out to them. Let's have a look. So I'm going through them now. What can be the reason for miscarriage?
The majority of the time, miscarriages are where the genetic material of the baby was not normal. It's the opposite. Patients they kind of put the guilt on themselves. They want to blame themselves, like, what did I do wrong to make this happen? Or what's wrong with my uterus to make this happen? The majority of the time, it's not that. The majority of the time, as humans, we make a lot of bad ones, and thank God the bad ones don't make it. And that's nature's way, or your body's way of kicking out a bad one. So genetically, when the egg and sperm come together, if it's not normal, or what we call an aneuploid embryo, the woman's body's trying to help it grow, but it can't grow. It doesn't have the right blueprint. The genetic material's not right. So it poops out early, before usually 6 to 8 weeks of gestation or pregnancy. So when it's a really early miscarriage, we know that the majority of the time it wasn't her fault or his fault. It wasn't stress. It wasn't all these myths. It wasn't right genetically. So the body, it can't make it, and it just fails and comes out as a menses.
Thank you for explaining a bit more about that. Someone has also asked about low egg count. We talked a bit about AMH levels. What would be considered a severely low egg count?
A good point. And this is really important for everybody to hear. Like, the woman's age is crazy powerful. And when it comes to egg count or egg reserve, probably the most important thing to remember is her age. If she's under age 35, 36, that's a good age egg. If the woman's 36 to 40, 41, it's starting to go downhill. And after 40, it's a bad age egg group. It's not the age of the uterus that matters. It's the age of the egg that matters so much. So age tells you, number one, about her egg supply and quality of egg. I think age tells you quality. Now, all these other tests, like blood tests, like AMH and FSH levels, tell us about quantity of eggs. Mm-hmm. So they're two different things. You have quality, which is more important in my mind, very related to the woman's age. And number two is quantity of eggs. So it's okay to have a low quantity as long as you have good quality. So if you have a young woman with low ovarian reserve, she does a lot better than an older woman with low ovarian reserve. So, but again, to measure quantity, we look at AMH levels or FSH levels. And a normal AMH is 1.0 to 2.0. And if it's under 0.8, that's kind of bad. If it's under 0.4, it's a nightmare. For FSH levels, if it's under 10, that's normal. But now FSH is a little tricky. You have to draw it on day 2 or day 3 of her menstrual cycle. And you have to get an estrogen level with it to make sure you got it on the proper day. It's like a balancing act between FSH and estrogen. So, but if you get it at the right time, on cycle day 2 or 3, you get the FSH level. A normal level is less than 10. 10 to 15 is gray zone bad. And above 15, you don't get pregnant.
Okay. Okay. And what can people do things to improve egg quality and sperm quality?
Absolutely not.
So not through diet and through supplementation and things like that?
Definitely not through supplementations, but diet does help to some degree. And we're not exactly sure how, if you have an obese patient and she loses weight, like, we're not quite sure what is it that it does help a little bit, not as much as you're led to believe. And we don't quite know, does it affect implantation or is it the egg quality? We don't really know what the weight loss does, but it is a slight improvement. So for those that are obese, losing weight's great, but all the supplements are bogus.
But what about men in terms of sperm? So obviously the normal, not normal, but quitting smoking, not taking drugs, not drinking too much. Women, that's all important.
Yes, you're right. So especially for a guy that has a bad sperm count and he's a smoker, definitely decreasing smoking helps. Caffeine's okay for them. Drugs are usually bad, like cocaine, marijuana. That can improve sperm quality for sure.
And what about
women, to some degree, but not as much. I'm sorry?
Getting more sleep for someone who's stressed and perhaps not sleeping.
Yeah. I mean, you touched on a common myth, that so many want to blame stress. When a woman first faces, or a couple faces infertility, typically they'll talk to their mother or a sister or a friend and they'll say, oh, it's stress. That's probably the number one myth that I dispel. We have beautiful studies showing that stress does not cause infertility. Beautiful studies showing it doesn't decrease sperm counts, it doesn't hurt the eggs, it doesn't cause miscarriage, it doesn't affect. But that's the number one myth I dispel. Now, we don't want the woman to have stress. We want our friends and family to be peaceful and not have stress, but it doesn't really improve success rates.
Okay.
But the one area, so scientifically, it doesn't do much. It's okay to be stressed to get pregnant. But where stress is the kicker is it makes you not come through our door. Like when the emotions are so bad or the stress is so bad, you won't seek advice when you need to go talk to people. So that is where stress plays a big part, is it makes you not come in to communicate, not come in to talk. And but it doesn't directly cause infertility otherwise.
That's a really good explanation. I think one of the most irritating kind of responses that people might get from people who, you know, family or friends who may not have been in this situation, and think that they're saying something helpful, but, you know, things
Yeah.
like just relax, you know, stop worrying, you know, things like that, where it's
Is
just,
it God's will?
yeah,
Or
exactly.
you get all this judgment, and they couldn't be more wrong in my mind. You're right. It can be very harmful, or it's going to be fine, or this is so emotional. You know, they really need to come in and talk to a professional,
Hmm.
and everyone's a reproductive expert. Oh my God, you know, you're right. Any woman that got pregnant without assistance in the past, they're an expert. Well, I got pregnant from this, and I got pregnant from that, and everyone's a reproductive expert.
Hmm. We had people saying after our first child when we were trying for a sibling, um, you know, I'm sure you could probably just get pregnant naturally. And I was just like, there's absolutely no way because we use donor sperm with IVF, so it's impossible.
What I like to say is when you get all these damaging comments, you want to stab them, but don't do it. They're just trying to be supportive. We'll get you out of jail. But try not to stab them. They're trying to be supportive. They just don't know what to say.
Hmm.
Yeah.
My husband's way of coping or dealing with his infertility is humor. And so he, you know, he even to this day he jokes to me that if I was, you know, pregnant, he'd know that I cheated on him.
Uh, I think humor is good in this. It's so emotional. I think we try to make it light and try to make it fun to keep patients moving forward. And
Yeah.
I really do believe in humor with this.
Yeah, yeah, exactly. And someone just talked a bit about finance for through insurance.
Yeah.
What's your suggestion in terms of like which insurers do you work with? How do you get the ball rolling with that?
Yeah. Us, like most fertility centers, we take all insurance, and times are improving. You know, 5 years ago, only 20% of the time insurance would cover it. Now, at least 50% of the time, your insurance will pay for fertility treatments
Amazing.
and testing. And what's really cool, insurance actually usually pays for like 100% of the time just to come in and talk and get the testing done. So
Yeah.
insurance almost always pays for a new patient consultation to discuss these
Hmm.
things and do some of the testing is usually covered as well. Now, the trick is, will it pay for treatment, the inseminations or IVF or what have you? And again, 50% of the time, insurance is paying for that now, at least in Florida and Georgia. So times are improving. It's getting better and better. It's not so much going out and finding that insurance. Like you can't typically go out and buy that insurance. You have to be employed under it. So for what I mean, like if you work for Amazon, oh man, their insurance is the best. It covers 100% of fertility treatment. Or if you work for Bank of America or Deutsche Bank, man, the insurance, whatever insurance they cover as an employer, it covers 100% of the stuff. And Starbucks is really good. And there's a
Yeah.
few other employers, it covers it completely, takes the financial pressure completely off.
Yeah, it's great that you know it's in the spotlight and things are changing to support people with it as
Yes.
well. Um,
Yes.
and someone said that they're 22 weeks pregnant thanks to you, Dr. Brown. So that's
Oh,
lovely.
I love it.
Um, and then there are various other questions. Thank you to everyone that's sending them in, talking about Globid, talking about embryo quality, talking about increasing implantation chances, procedures for women that get pregnant but have miscarriages before 4 weeks. Perhaps it would be best for people to sort of DM Brown directly to arrange a consult with Dr. Brown to cover some of these
Would love
because
that.
some of them are quite personalized questions. Um, so yeah, thank you very much for your time. Yeah,
Yeah,
there's
you're
lots
so
about this.
welcome. And
And thank
we'd love to. Our goal is to help everybody have a family and a baby. And the good news is nearly 100% will, if they're willing to follow the path we put before them. And sometimes that path can be tough, like choosing to use donor sperm or donor egg. But the majority don't have to. The majority, if they just do what we tell them to do, the majority will have success. So there's a lot of hope and promise here, and we love it. Couples come in suffering, and they always leave happy as long as they can just stay on this path and keep moving forward.
Mm-hmm. Absolutely, absolutely. Well, thank you so much, Dr. Brown. And for anyone watching, please do head to our link in bio to read more about, you know, where to start with subfertility, infertility, fertility generally, and next steps.
Thank you. Have a great
Thank
week.
you, everyone. Thanks a lot. Bye-bye. Bye.
Bye-bye.